Right. Good morning, class. um, First is let me get used to these things a little bit. Right. Welcome you all back to a new semester. Probably the last one for you guys. um, One thing that I want to say right now is that my camera has not been working lately. And for that reason, so far I've been using or doing the classes, lectures without uh, me being visible. But I have thought about now trying to, instead of relying on my computer's camera, inbuilt one, and to order another plug and play one and make it be workable. Because maybe having me on the screen um, probably could make things a little bit more attentive. My voice is not clear, so this is another thing that I have to work up with you guys. So is there, because a lot of uh, students have internet problems. So for that reason, maybe their internet speed is not good enough, and that's why they have voice problems. So I am constantly looking at my screen for the chat messages. So when I'm talking to you, the best way to communicate with me is through chat. All right. So if you have any thing to say, any comments, any problem with the screen being stuck, me forgetting to let it move or whatever, or the sound, you can tell me about that here. So there are a few students who are saying the voice is not clear. In my opinion, it should be clear. uh, so what about other students listening to me? Is the sound clear or not? Clear, 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 not clear, clear but low. Okay, so let me then try one more thing. Not clear. Okay. Just not you. Bluetooth headsets. So how about now? I've now removed the Bluetooth headphone and hope that it would be better. Now good. Okay, better. Clear. All right. So it means that without the microphone that I have is a better way to talk about stuff. All right. So this is section B, isn't it? Section B. All right. Another thing, please confirm if you guys can see the chat box on your screens or not. The chat for this, meeting. You cannot see it. No. Okay. So that's why I wanted to mention it, because that chat box, I keep it on the front of my screen. Mostly, almost always, even when I'm delivering lectures, when the slides will be going on. So I'm constantly looking at if you have something to say, almost always. So this is the best way to communicate with me. Otherwise, I mean, if it's not working, you can. I will, you know, let all of you guys have this, uh, yeah, opportunity to unmute yourself whenever you want. So any one of you can unmute yourself at any time, pretty much, you know, and right. So uh, if the chat is not working for you to get the message to me, then you can unmute yourself and speak up as well. Um, Otherwise, make sure please that your mics are turned off. Everybody works differently, so maybe other teachers may have a different routine of doing things during this meeting. class sessions. That's why I want to, make things clear the first time. There's a certain way of things and routine of the stuff that I do, during the lectures, and even for the stuff that I do after the lectures for you guys, and make things available for you. So that's one thing. Secondly, yeah, make sure that your mic is turned off, especially for the people who are attending the classes on mobile phones. Because at times it happens that you're using other applications and they're using mic, and the mic is being used then for Chumo as well. So please, sorry, when in class, um, make sure that you're attending the class and paying attention to what's happening, what is being delivered, what is being talked about. And one reason is that you are basically present for that reason, right? And if you just here for attendance, then obviously you may have some issues when random people are going to be picked up for questions. At times, I do that during the class. Maybe you remember that already, but I do more so often during these online sessions, because otherwise, I mean, how to keep you guys, on your feet and attentive and listening to what we're talking about, paying attention to the stuff. So if you're unable to answer something precisely, that's still okay. I mean, when a question is asked, ideally the answer should be there, but otherwise, at least you should know what the question means and what the, what kind of subject area, topic area we're talking about. So at least you should not be clueless. If you are completely blank and clueless, that may indicate to me that you do something else, you're not paying attention, maybe you were sleeping. Right, so for that reason, penalties can be there as well, which is basically for each question answer session that I do. So when I do it, I just randomly pick a few students every now and then. So it's not that every single student is going to be asked question every class randomly, and then for that reason, I keep a track of score as well. So roughly, I have like my intention is to give 3 to 5 opportunities to each student throughout the semester, right? So I score you guys for each of those opportunities as well, and this in part is your internal assessment as well, right? For the score for internal assessment is from this question answers opportunities that you get throughout the semester, which I just mentioned as in total 3 to 5. It may be three just questions that every student may get, or it could be at most up to 5. Is that clear? So if it's not clear, if you don't understand what I mean to say or what I'm saying, just mention that in the chat. Right. so uh, so this is one part of internal assessment that will be going on. The second part of internal assessment will be assignments. So there are assignments, and by assignments, I mean to say when I will ask you guys to, whenever I ask you guys to, mostly, right, to study something, that will be one part of your activity, and the second part of the activity will be to produce, uh, a document out of your studies. So what have you learned out of that? Most of the times I'll tell you what to write on the topic areas or the aspects of the topics that you need to now write, the information, write about the information that you would have gathered through your own studies on that topic. So usually whenever there's an assignment, it's these two parts, right? Sometimes I may just ask you to study so and so topics from so and so places, right? But mostly it is to study as well as to produce a document after those studies related with that topic area. And there is a submission for that as well. And the submission happens online. I have managed to get a system for that. So whenever it comes to an assignment, the CR, and for B badge, I think it's Tony, right? So Tony or whoever else takes responsibility for this, communicating with me, will be responsible to get the link from me. So when I share the link with you guys, that link will be that for each specific assignment. It will have a number as well for it. Obviously, first assignment will be assignment one, and so on and so forth. And when you open up that link, there will be a few fields to fill: your name, your roll number, section, stuff like, and the topic of assignment. And then at the end, you can upload the images or pictures or screenshots. So it's an image upload that you would do. You can upload at most 6 images. My requirement is pretty much for each assignment when you do it, to do it minimum one A4 size paper length. Now, obviously, each paper has back end, you know, front side. So my minimum requirement or minimum acceptable length for an assignment, depending obviously on the questions, but the minimum expected length of an assignment is one A4 side of a paper, A4 paper. A4 paper is the usual paper that we use for photocopying, isn't it? So it's one side at least, and then obviously it doesn't mean that you just write big big letters and whatnot, and just 4 lines are A4 size paper length. That's not it. I hope you understand what I mean to say, because otherwise this will also be scored, right? So let's say throughout the semester you get 5 assignments, supposedly. So these 5 assignments for each student will get scored as well, and then this score, along with the internal assessment of, that question answer sessions, will contribute towards your internal assessment. Okay, clear? Now, these assignments can be handwritten, they can be typed on PC or even a typewriter if you have it. So it does not matter how you write it, right? It can be printed as well, but it should be your, you know, created content. And to create this each assignment, my recommendation is not to just read that topic from one single book. When it is an assignment, the requirement will be to study from multiple sources, multiple books, and even online resources. And then, finally create this assignment content, right? That's general instructions for any assignment that you will get. So it's not just that you go to the book, read from the book, and copy from there and simple. That's not it. Okay. So the goal is for you guys to explore that topic area, understand it, and then gather the information source from different resources, reliable resources, and then write down the assignment, whichever means you use it. Let it be typed, let it be printed, let it be handwritten, all is fine, but the length should be the way I just mentioned. All right. Okay, so that's for the assignments. Now, for attendance. Um so where is Tony? Is Tony here or not? Listening to us or not? Any other CR than Tony responsible for stuff? Tony is here. Okay. So I will send you, or maybe you already have an attendance file, right, Tony? So what you are supposed to do is to, um, you know, look at the list of participants in each session. You don't have it, so I'll send it to you. So look at the list of participants in each session, and I would recommend it to be done um, at at latest like 15 to 20 minutes after the class starts. Reason for that, internet problems and connection issues. Some students connect and then they disconnect. So in my opinion, up till like 20 minutes past, whoever can join the class, does join the class, is present in the participants list, ideally would get the attendance. Unless I ask them a question, I'm trying to talk to them, and I do not get any response back. Right? Let's say there's a student in the list, and I'm trying to, unmute them. I can listen to the other side, a student side, and I'm speaking to them, and maybe, right, everybody else can listen to me, and there's no reply. So in that case, it means the student is just not there, simply logged in, left the PC, and not there, or is sleeping nearby. That's the two assumptions, the only two assumptions that I can make. So for that time, their attendance would be taken away. Okay. Obviously, if the student comes back and whatnot, they can still, uh, you know, if there was an actual problem, we can get to that. But otherwise, this is the usual assumption that will be taken. Right? Especially if I can listen to them, their mic sounds coming from the back, and they're just not speaking. Right? Or if least I don't get a reply in the chat from them. Right? So if the mic's issue, at least reply on the chat, isn't it? So these are important things, because obviously, you get limited number of opportunities, each one of you, during the semester. Right, and attendance, as I said, Tony, 10 to 15 to 20 minutes after the class starts. By that time, you should have already noted down yeah. So you should have already noted down the roll numbers and marked the attendance. And for all of you now sitting in the class, please make sure that your IDs appearing in the participant list on Chumu in this meeting are two things, and both of them are present in your name ID. Number one, your roll number. Number two, your name. By roll number, it means complete roll number, please. Right? Not just 117. Right? Like 217, 117. So complete roll number should be included along with the name in your uh, this ID of Chumu, right? And if I see a student who is not that way, whose ID is not that way, there can be penalties for that as well. Like this, you go, there's a student 217, 128, no name with it, right? So fix this from next class onwards. It should be both complete roll number and the name. Understood? Okay. So other than that, um, yeah, about the students who are sick and ill, and for some other. First of all, tell me if some of you guys are in China still or not. Are all of you back home in India? Are there any students still in China? Because if there are some students in China, then I'll have to be some still in China. Is that, Tony, is that sure that there are some students who are in China? So for that, if they are actually there in China, then I'll have to, when I upload stuff, I'll have to upload it to both, uh, only a few students, but still they are in China, so they won't be able to access Google Drive that I mostly use now for uploads and shares with you guys for lecture recordings and other slide stuff and other stuff that I keep on sharing with you guys. So I'll be using both Google Drive and then Vision, the Chinese one, because Google does not work in China. So then the Chinese cloud service Vision. So both are going to be uploaded. Both basically will have different folders in them, including a folder for these lecture recordings. Uh, including for daily PPTs, another folder, uh, and a folder for the books that I'll be sharing with you, and any other, you know, articles and images or videos that I would like to share with you guys will be having uploads there as well. Right. So a document will be created for the links for those folders, and then that document will be shared with you guys, which then you can keep with yourself, and then just those folders will be updated every time I add stuff to them. All right, so that's the stuff with sharing with you guys. Now, for those students who want to, sometimes they just don't have any option and are going to be absent, please do not contact me individually for any reason if you're not going to be there for short or long purpose. I do get it that some obviously students have serious problems, issues, constraints, and at times are just unable to be present in class for short or long period of time. So whatever your concern is, you must talk about it with your headmasters, headmistresses, and then once you come to an agreement with your headmasters or headmistresses that you are given leave or not given leave, right? Whatever the consequences, with the proof of that, right, you should communicate it to the CR, and the CR should communicate it to me. And as the CR is the one who is marking attendance, uh, if you've got leave, they would CR would inform me about it, present obviously the evidence as well, which would be an approved application, for example, um, and simply mark them as present because there's nothing called as leave, right? So such a student will be marked as present so that their attendance score does not get affected, because obviously minimum attendance if not achieved can lead on to not sitting in the exam. So understood. You guys talking directly with me won't have any consequences. You can talk with your headmasters and mistresses, and if they allow you, looking at the whatever you provide them with, um, then the CR can let me know about it, ask me about it, and then do what I just said. Understood? Because it keeps on happening and it creates problems and confusion for students as well as for me as well. Right? So I don't want any confusions. Everything is dead clear. Um, so about now, this semester, are you guys aware what content are you going to be studying? Yeah, no idea. Okay, so let me mention the varieties of chapters, or I would say some of them being subspecialty areas as well that will be talked about. So there's going to be geriatrics, the first chapter that I'll basically touch. There will be emergency medicine. There will be neurological system. There will be nephrology or urinary system and endocrine system. So these are in total five chapters, let's say, or subject areas or subspecialty areas. Because basically, in not all universities have just medicine, the name of the subject, going throughout the last three clinical years. Medicine is divided into these subspecialties, and then those subspecialties are minor subjects on their own. But here, obviously, I mean, this is also perfectly fine. But just to say that these are basically uh, small subspecialty topic areas that we'll be talking about. The first one is that we are going to be talking about is geriatrics, and it's comparatively much shorter lengthwise.
and simpler as well, I would say, content wise, easier too. Um, but it's a little bit different in the way that it is put together. So, how is it different? Um, in other, let's say, just a minute. You want to use PowerPoint. Okay. So, is my screen visible to you guys now? And do you see the slides? First slide, geriatrics. All right. And let me do one more thing, which is to turn off entry exit time. All right. So, a few comments on this area or subspecialty of geriatrics. You know what is it? Anyone who would like to comment on what does it? Yeah, it is basically the branch of medicine which addresses and is concerned about the care of elderlies, right? And if you say that, senior people, old age individuals, elderlies, whatever you would like to use. So when we say that, what age group do you think, or range of age uh, is that we would talk about here? Meghna is saying 70 and then 60, 65, 65, 60, 60. So it's generally around that area. More specifically, it's 65 and above. So the age range that is included in this, area of geriatrics is 65 years and above. But not all 65 years or even 70 years elderlies are going to need special geriatric care and attention, right? It depends on, um, you know, personal lifestyle and individual's health scenario. A lot of people who are 70 even and up to even 75 are quite healthy, very much functional, very much independent, and free of major health concerns, right? So it's not necessary that everyone starting from age 65 would require special geriatric care, right? So, but the age group starts from 65 onwards. That's one thing. Yeah, so someone's mic got turned on. Right, so 126, and lonely old people separated from family. Basically, this is what I'm trying to. Before we actually talk about specific stuff, I want to mention these, general pointers towards this area of geriatrics. Number one, aging is inevitable, right? When we age, our normal, usual physiological and physical capacities deteriorate, right? So the age will have its own toll on us. Diseases, health issues, be there or may not be there. Aging on its own also has effect on each person variably. Some get affected more, some get affected less, depends on so many variety of different factors, right? But everybody ultimately is going to have a basically a declining trend of health, right, as they keep on aging. So that's one thing. Now, on top of that, when you add um, different varieties of health issues that a person may face for whatever reason, genetic, environmental, lifestyle based, nutrition based, whatever, whatever the actual cause may be, which may have led on to the person be suffering from a certain disease, a major one, or multiple number of diseases or health conditions, whatever the reason may be, they all then come together, their effects, and that effect adds up to the effect of aging. And therefore a person's uh, you know different varieties of capacities start to be affected, right? And what happens is a person who used to be, now this is very important to pay attention to, because otherwise, this is the holistic model of health that we, if you're talking about this subject area, geriatrics, then you're definitely using the holistic model of care. Remember that we talked about in the first semester of medicine, different models of healthcare, and then the holistic one, in which we don't only think about the disease, but the patient as a person, as a living human being who has all the feelings and the life and the relationships and the concerns and the privacy and all that, right? So, if you are a person who cares about all of that and actually cares about taking care of all those concerns and uh, you know uh, basically areas to be worked upon, then only you will be able to address the concerns of geriatrics as a subject area too, because it's a lot about that, right? It's not just about looking at the illness. For that reason, so another reason that I'm mentioning this point here is that the topics that you get in this content are not entirely or only going to be talking precisely about the disease itself or the condition itself, or it's not going to be only talking about how it presents with which signs and symptoms, or only going to be talking about which drug to use and just that works for it and that's it. There's so many other things which are minor things, apparently, um, may seem very less important, right? And may actually seem like that you may overlook them, and academically as well, for example. But those are the exactly things which are the most important ones, because in geriatrics you basically have to take care of those multiple minute details and things that generally we overlook while taking care of a younger person, or that we even know that are supposed to be paid attention to, but we just don't, because we know it's those things are some things which are so minor that even if they are present, even if those factors are working on the person, won't make much of a difference for that age group of a person, for a teenager, for example. But when it comes to an elderly person, the whole scenario changes, right? An elderly now, in a person of this age group, is a person who has lived for that many years, has actually, physically endured those years of physical activity, of mental, engagements, of worries, of pleasure, happiness, and all that, right? And would probably have retired by this age now, in most cases. So, this used to be a person who was independent in most cases. He was used to be a person who was very likely proactive, was very lively, was very healthy, right? And probably would like to do many other things other than just the daily necessities, or let's say the daily necessary activities of each day, which include basically getting up, cleaning up, eating, going out, right? Traveling, and doing anything required for these things as well. Um, Cleaning, right? So we'll basically name these activities and some others as well, and certain categories later on as well, right? So before this age arrived on this person, right, and probably they retired, or even if they're not retired, even then, before this age group, when they used to be younger, they would have been doing or would have liked to do a lot of other things, a lot of other activities other than these daily life chores, let's say, or activities, right? So when they were doing that, they were quite proactive and they had a life, as they say. Now, because of multiple reasons, because of the age, because of the physical limitations, because of maybe existing conditions, or one single major health condition that they may have, or because of just being retired, right? Because of the children moving up, their whole life has dramatically changed now. And it's extremely important stuff to keep in mind. For that reason, because this is a holistic model of healthcare that we're talking about, for this very reason, now we've established that this person who is 65 years age and more is a very, very, very different type of a person, isn't it? Do you agree or not? Compared to younger ages. Yeah. So this person is very different. Number one, their priorities are going to be very different. Their concerns are going to be very different. The word happiness, the word life, would mean very different things for them now at this age, depending on whatever their scenario is, whatever they're suffering from or they're not suffering from. So these things mean very differently to this age group and to the age group prior to them. So, and then this model of, and then as I said, if you're talking about this specific subject area of geriatrics, you are caring. I would say you're extra caring for the elderlies as you should. The problem is that this extra level of care mostly is only catered or is paid attention to in developed countries. Reason, health systems. Other reason, um, I would say finances, and they are major thing as well because it costs to get this extra level of care, right? For example, there is a thing called as care homes as well in Western countries or developed countries. Old age homes and care homes and nursing homes, the different varieties of names for them. And believe me, it costs like more than 80,000, sometimes 40, 30,000 US dollars. And it goes, as lavish and a good kind of a setting that can be provided to the cost keeps on going above. I've heard as much as up to be 100,000 US dollar a year cost for keeping your loved ones in a comfortable, well taken care of an environment, right? So that's the cost, financial burden aspect of it for this extra geriatric specialized attention that this age group kind of people need, right? So either this can be given by the family members if they're living in a home, or it can be given, obviously, then by professionals when they're living in a care home, right? And mostly, I would say, um, it's provide this level of care. and specialized care and attention is only provided in specialized settings in care homes. If an elderly is living at a home, we may respect them. That's another thing. We may be around them and we may, uh, you know, do whatever we can for them, but it may not mean that we can actually take care of all of their concerns and preferences as one should, right? So that's a broad topic area to actually talk upon, but it's a fact, right? So as we keep on going on, you'll see that there's so many things as a doctor to pay attention to, because to be tested, to what extent to be tested, to be treated or not to be treated, or to be treated with what variety of treatment option, and to go through what level of you know hassle to be having those tests and to be having those treatments or surgeries. All this has varying degrees of discomfort, side effects, and maybe side in terms of side effects, maybe long lasting ones as well, or permanent ones as well, likely to be associated with these kind of activities. So it's a choice, right, that an elderly has to make. When they have to make a choice, the choice has to be informed. When they need to be informed, then they must have the capacity to entertain that information and analyze it. So then there's so many different topic areas that I'm kind of now touching on to help you, get the gather the aspect of this subject area that it addresses. So for that reason, the topics that we will be having in this chapter may have the headings of clinical findings. But when you read through it, it may not literally be the clinical findings. God, you would have studied that disease likely somewhere else, or maybe you would not, because there's still a few chapters remaining for you to study in medicine, right? So you may not have studied that disease, but when you do study that disease in that separate chapter, there will be the details of clinical features and the presentation and whatnot. Here, when we talk about geriatrics, our concern is basically in this specific age group, how does that specific condition present itself, or what is more prevailing variety of sign or a symptom, let's say, if there are any, and with the given coexisting conditions in this certain age group with men and women, what has been seen, I would say, traditionally through record to be happening, or what variety of presentation has been more commonly seen to be taking place, right? So these aspects are going to be more found, and then what to do, especially in this age, and then most importantly, every single comment, statistics, features, presentation, whatever we talk about in this chapter is specifically for this age group. Nothing that you'll see basically may entirely be applicable onto any other age group of individuals. You have to keep that in mind, right? So this thing is most common. So keep in mind, whatever we're talking about in a certain specific topic area, it still applies to the elderlies in general. Okay? Because otherwise, there's so many things that are variable here, and you guys may actually be misled that way. So keep that in mind. All right. So uh, then again, because this subject area is more in practice and is more of a concern and is more paid attention to in Western countries and in developed countries. So for that reason, again, as I said, you may feel like that this is less important. The point is that even in underdeveloped countries, you can be the doctor who listens to your old patients, who pays attention to these things. And you know, your goal is to treat the patient. And for this age group, if you do not pay attention to these things that are going to seem less important, right? I pretty much am sure you will most of the times not be able to effectively treat the patient of this age group, right? Because the problems that they are facing are multifactorial, right? And they need an approach that basically includes all those minor details as well, right? So, therefore, you have to now bear all of that in mind that I have just made comment. What's the time? The time is 53. I think you, what time is the break? We have 5 minutes break or 10 minutes break? Oh, how many minutes are the break? 5 minutes. So 2 more minutes. Let's take a break now and properly start now the content after the break. All right. So this my by my watch, the time is 53 past. All right. So or 54 past now. So 5 minutes break. That means it's 11:54. So I'll be back at 12 on my side. On your side, 12:30 on India. Right. So for Chinese students, just count 5 minutes. I'll be back. Yeah, let me check. I'm checking for the schedule, teaching schedule. Yeah, the break is 10 minutes. Just check the timetable. The break is 10 minutes. So 10 minutes from now, we'll be back. I'll write it down here in the chat as well. All right, guys, I'm back. Please confirm that you can hear me. Yeah, all right. So, hopefully, everyone is back by now. And let's start with the. Okay, so the general structure of each topic, pretty much. This is not the first. A general principles is just a general principles, basically for taking care of the elderly. But later on, for each topic area that we have, the structure of each topic will be basically general information for that topic area, for a illness or a condition, because not everyone, for example, falls is not an illness, is it? Right, so it's not a condition, but it's something that happens to elderly, is more common than to younger people. So when a topic area comes up, there will be a general bit of information in which, let's say, for example, some statistics, some information, some uh, general, information will be available. Then there may be information related with uh, clinical findings, or physical examination related information, in which there will be information about, basically, if there is a specific way of presentation of a patient of this age group, then that would be present, or uh, what can be done to gather information for signs, symptoms, or assessment of the patient, for example, right? So, for example, what variety of, if there are any certain ranges of tests to be conducted, they may be mentioned to gather information, or specific tools, right, to assess a patient, if present, would be mentioned as well, right? So at times there are questionnaires, at times there are certain type of physical activities required to be done by the patient for us to assess them, right? So stuff like that. So when they are mentioned, we'll talk about them, and at times look at them as well. Then it's about, let's say, the causes, because then again this is a special age group, so the variety of scenarios, problems, issues which could lead on to basically an elderly facing the problem, that is the topic area, right? So those multifactorial causes, sometimes actually classified into different varieties as well, quite a lot, so they will also be there. And then prevention and management, right, of that, what's happening. And this prevention will have basically the preventive measures, how basically to prevent so and so things from happening by actually most of the time addressing the coexisting and controlling the coexisting conditions. But then, you know how can actually that be achieved? Best case scenario in this age group, right? Because, as I said, it may be very obvious, sometimes may not be very obvious, but here in this subject area we're talking about the best case scenario, the approaches to deal with uh, this age group more than 65 years. When it comes to management and treatment, uh, obviously, sometimes, not always, sometimes, the obviously depending on if it's actually a disease or if it is a state that has happened basically. So how to, for example, falls, how to avoid falls? Are you going to give a person a pill to avoid falls? uh, what is your answer going to be? That's an interesting question. Are you going to prescribe any pills to a patient to avoid falling down, or there's something else that can be done as well? So, if you look at why the person is falling down, then you'll come to multiple reasons, and then some of the reasons will be drugs as well, right? And some of the reasons will be some conditions, other conditions that the patient may be suffering from. So, that's interesting. That's why I'm saying sometimes discontinuing drugs, sometimes actually giving drugs, and sometimes addressing some other issues, right? The causes for example, the fall needed to be addressed as well, right? So management, no sir, we will tell them to buy good shoes. This is actually one of the recommendations in a patient, because falling down is actually a major concern for this age group. And when they do fall down, if somebody falls once, there's a chance that they would fall down twice. And there's so many issues related with the sensory, input, and balance related, gait related issues, medication related problems that the patient may already be in. For example, antihypertensive medicines, hypertension may be a problem. There's many things that you'll come across. The point is all that, and yes, the shoes are also one of the recommendations, to buy a better balanced shoes, right? So those are the recommendations. So that kind of stuff, right? So it's not just related with medicines or prescriptions. It's about other advice, which is crucial when you come down to this age group, to help treat and prevent the problems of the patient, right? And then towards the end, after management, is about when to consider referring this patient basically to other specialities, and when to consider admitting the patient basically in the ward, right? So this overall is the structure for each topic. that you will get in this chapter. All right. So, first of all, the disorders of this age group that are going to be addressed are almost always multifactorial, right? So, for example, if somebody is falling down, as I just used this example, there could be multiple reasons why they fell down. Maybe there was something in their way and they didn't see it well. Maybe their eyesight is not well, right? Maybe their eyesight is fine, but they were using some glasses, right? So it's, and the glasses they just started using a week ago or maybe a few days ago, right? And whenever anyone gets new glasses, could actually be not comfortable with them and could feel dizzy. Maybe they're using specific glasses that we'll mention later on, which can actually be causing dizziness as well, right? So, and then there could actually be a neurological deficit in a person's, leading on to their balance and gait abnormalities, which contributed towards their falling. So there's multiple factors to be considered and to be kept in mind. So when you keep all this in mind, it's helping you to evaluate this age group of people, right? Once a person falls down, then they actually have risk factors uh, to be actually dying within next 2 3 years as well. This is a important stuff, right? Seems like easy bits, but it's crucial for this age group individuals. Therefore, when we try to treat these individuals, manage their problems, improve their life, standard of living, and their state of being, we need to approach a multifactorial methodology. Right? So it's not just going to be using medicines or surgeries, but it's going to be more than that. Right? And the thing is that in the books, I've been saying this even in pathology a lot of the times, that not all this, what we study in the books, the presentation of a disease is what we call a textbook presentation, or otherwise a typical presentation. That's the are you guys listening? So I'll be asking this as well quite a lot of the times, because when I don't see any yes, no, clear, a bit of comments here, there, and chat, I could be disconnected. You never know. It does happen. So I'll be asking every now and then if you guys can hear me and are following me or not. All right. So that's a typical or a textbook presentation. And even in compiling that information, there's been research is going on. Research has been done a lot of the time, and they found out that most of the time this certain disease or a condition presents mostly with those repetitive signs and symptoms. So that's what you get as a typical presentation. But it does not mean that that same condition or disease may not present some variably, some otherwise. Some of those symptoms may be missing, or some other variants of those symptoms may be present, right? Which could present a bit different. So that kind of atypical or non-specific presentation is more prevalent in this age group, right? And there's also multiple reasons for that. Few of them are that these individuals a lot of the times are suffering from multiple diseases, multiple conditions, are on multiple drugs, and basically those drugs and their effects or side effects could actually be causing certain symptoms, and therefore, as we say, clouding the presentation of another condition. Does that make sense? So things become confusing at times, right? And then, with all of that having been said, the fact of the matter is that in this age group, treatment is not always the outcome or is not the desired solution. Why? It depends what the patient wants. They are in that certain stage of life, state of mind, right? That they may first assess, listen, analyze. Okay, so it will be requiring a test. For this test, I need to do this. I'll be having to go through a that procedure. There'll be a needle, there'll be poking of a needle, it will hurt. I don't like needles, whatever, right? The point is that number one, um, we need to basically do all of this in relation with the preferences and values and goals of these patients. What do they want out of their daily life, right? What do they do they want anything more to be happening in their life? Do they want it to be a better? Do they want their walking to be a bit better, for example? Do they want less pain? Because at times they're suffering from pain in joints and bones and head and whatnot, and then they've got accustomed to it, and they're like, I mean, it's okay if this bit pain remains in my joints, for example, while trying to walk. I mean, I'm fine with that. Instead of having to take drugs, which then start to cause pain in my muscles of the legs and whatnot, and then I can't even sleep at night, right? So it depends. What do they want out of their daily life? Do they want any improvement or not? For that very reason, we as physicians also need to make an assessment of, will you know doing a certain test on a patient or a treatment on a patient be of a value enough that the patient will benefit from it, or even if in your opinion they would benefit of it, do they want it even to go that far, right? To get that benefit after a certain amount of suffering, maybe, for example. So um, not everything will require a treatment in this age group. And how to basically come to that point, to float this idea in front of these patients that, I mean, it's better for you to do this test and treatment, or um, I mean, if you do, or otherwise, second option, for example, you could do this test, but the benefit that you may get out of it would be outweighing the possible or probable harm or a side effect or suffering that you'll have to go through it, right? So when you float these things to in front of the patient and your opinion that it's better not to do it, then they can make an informed decision out of that. Right now, this is being done in comparison to, for example, a young age group, a teenager, for example, that who has a whole life ahead of them, right? Decades of life ahead of them, and you won't be thinking about all of this while making your decision to go for a test or a treatment in that age group. I hope that makes sense, right? Dynamics are totally different, right? So, for that matter, we'll also have some ways to establish how to come to that point. Is it better to do a certain test or a treatment or not? Will they be benefiting from what is basically as the expected lifespan? Even if I treat this disease, or if I do this test and then find a problem and then treat the disease, will I be adding anything extra to their lifespan, to their quality of life or not? Right? These are the questions to be kept in mind. So, the frequent challenges basically in while coming across these individuals and their problems that they suffer from are that they suffer from complex conditions for which they may be on complex multiple regimens, which means they may be on a certain group of medicines for one condition, for example, uh, a couple of drugs for controlling hypertension, right? As a combination dose once a day, maybe, or as a separate two drugs, one in the morning, one in the night. That's as a certain regimen for hypertension. Then for diabetes, a certain one. So, and then on top of that, they may also have some arthritis, right? So they could be on multiple different regimens, and these drugs could actually be then interacting with each other and causing some issues. So there's quite some challenges. Another issue, major one in elderlies, because of then again multiple issues, is adherence. What would be an adherence problem? The word should be obvious. It's adherence to the treatment prescription, right? And if a doctor has actually prescribed a certain drug or certain varieties of drug to a patient, I mean, if the elderly chooses to take it or not, or even if they can remember to take it or not, right? These are actually the things to be observed and noted by the physician. And then it's physician's job at least to recommend to the patient and their relatives and their caretakers and their attendants that, this is the best thing for the patient now at this age, right? If, let's say, for example, if they just end up by, even after trying all the possible measures that can be taken to address the adherence issue, right? To address missing of dosages by the patient. If everything has been tried upon and it's not working, then what to be done is doctor's responsibility to at least advise the patient and their relatives. For example, in terms of dementia patients, before dementia gets to us, this is also going to be a next topic basically, or not the next, uh, second major topic. So when it comes to a certain stage of moderate level of dementia, it's basically doctor's responsibility to advise the patient as well as the attendants and relatives, or caretakers of the patient, that uh, this patient now needs to plan for multiple things before dementia gets to a certain stage where it will become even difficult, further difficult to impossible for the patient to handle and manage crucial activities and tasks for their daily life and for their future, of their own life as well of their possible, next of kins. So it's doctor's responsibility to advise at least. If doctor does not float this idea, who will? Right? Then it can become actually an issue, and then it might get to the point where patient loses basically their memory, to a great extent, starts to affect their ability to handle their own, for example, financial matters even. So there will be a counseling and advice for that too. So adherence issues are also there related with uh, taking the dosages of the drugs. And polypharmacy, as I've already mentioned, multiple number of drugs for multiple number of conditions at times being taken, their interactions with each other, their side effects taking place, and sometimes one, you treating one condition, or treating multiple conditions, leading on to giving rise to another geriatric problem, for example, falls, right? For example, antihypertensive treatments, most of them that we give, when you give, for example, beta blockers and whatnot, when you give to the patient, dizziness, and risk of falling is there as well, right? So you could be treating one thing, causing another thing, and in this age group, that second thing could actually lead on to further very high risk factors for this person's well-being later on. Right. There's quite a few chronic existing conditions as well, a lot of the times in this age group, right? So, management that we do for this age group patients for any condition has to be in concert with one another, which means, so this also in developed countries basically these days is done by the system, right? So, in developed countries and Western countries, you don't write prescription. Even in private practices, you don't write prescription anymore. It prints out from the computer. You choose the drugs from the PCs, right? And when you have chosen certain drugs, right? So it means you're prescribing this one drug, second drug, third drug to a patient through that system. If there's any adverse interactions of drugs that you've chosen, they will be highlighted in the system by itself, and that's how it should be. Because obviously we're human beings, remembering every single thing is not a perfect way of basically going about this. We're playing with the life of a person. So it becomes much easier in those countries with those systems. Even in our countries, I think the hospitals which have become more digitalized have this going on. So therefore, management of conditions, whichever problem at hand for our elderly that we're doing, has to be done in concert with one another, not interfering with each other, causing another problem. Now, to be dealing with all of this, we have to assess these older individuals. And basically, in assessments, there is, I think, generally we call this assessment as comprehensive assessment. And this comprehensive assessment has three major aspects to it. One, assessment of prognosis. Two, assessment of values and preferences of the patient, right? And assessment of functionality, simply saying, or which means independent functionality. Right? Which means if the patient can be on their own and function well, appropriately on their own, without depending on another person, and then that means that they are able to carry out a few categories of activities each day, that we will basically name the categories as well, which is daily life activities basically, right? So now we'll categorize them differently. So assessment of prognosis, how do we do that? We have basically majorly there's like two themes to this assessment. Number one, um, assessment of individuals who are suffering from a major uh, health condition, right? So their overall problems, condition, presentation, presenting complaints are majorly caused by one single disease or condition, right? So that variety of patient can be assessed in a certain way. And then another variety of patient whose chief complaint, problem at the time of presentation is not caused by one major underlying disease or a chronic disease, right? So then that's two separate categories of individuals, right? And then in assessment of prognosis, basically, then again we divide these these age group individuals into two categories. The ones now which will have life expectancy at their age to be greater than 10 years, right? And then the second category of this age group individuals who at their age have a life expectancy of less than 10 years of age. So if they have a life expectancy of more than 10 years at any age after 65, right? So it becomes this is a significant long period of time, 10 years, at least 10 years and more, right? So it becomes reasonable to consider all the tests and treatment options that you would think about for a young individual, because they have a good lot of life in front of them. Now, how will you actually assess or estimate their possible life expectancy coming up, right? But at the moment, commenting on if their life expectancy is assessed to be more than 10 years, consider all varieties of options of available tests, avenues, right, of treatments as well, and treatment options, and present to them as you would do for a young individual, right? Make sense? Yeah. All right. So, and then the variety of uh, patients in this age group whose life expectancy will be less than 10 years, and then for them, um, the tests and treatment options, whichever we would be having in our options list, only they will be considered to be offered to the patient, obviously because it's their consent that you need. But you will be considering it, and therefore if you consider, you will present to the patient as well, only if by doing them you are sure that they will improve the patient's prognosis and quality of life. What does that mean? It means that after those treatments and the tests that would be required to be done, right, on patient, their life expectancy would improve. And then the way that they are living their life every day, right, they will be better at it. They will be more comfortable. They will be able to do more every day, right? Not just as much or less than before, right? So we're going to be considering the tests and treatments, the possible available ones, only if they bring about this significant improvement to their expected time for which they will live after the treatment. Now it becomes more than 10 years, right? And if it improves their daily life, extremely important. And keep having said all that, we will still have to remember that you know these are elderly individuals. They already have possible multiple conditions, underlying problems, right, which may have already been identified, some may not be identified. So the chances are that their prognosis may deteriorate more than you have assessed already, right? So for that reason, this is extremely important that whatever we do with them in terms of tests and treatments, right? Sometimes they're very simple, other times they're quite invasive procedures, right? So when we do them, the benefit that they're getting out of that procedure or test or treatment option, the benefit is more than the harm, right? So these two are important things. Number one, the benefit that they get out of it, and in term more being more specific, that the prognosis improves and uh, quality of life gets better, right? And even if there's a patient whose prognosis has deteriorated, then in that case, in such a patient's case, whose prognosis has already become worse than previously assessed, whatever treatment or test you want to do should benefit them comparatively more than it has potential of harming, right? So that, so remember I mentioned two separate categories that we can otherwise divide them in. When one category of this age group individuals, a person comes to you and they, let's say, have diabetes, right? And the complication of diabetes are multiple, right? So they could be having multiple symptoms and problems, but that it's dominated by this one condition. So condition dominated by a single condition kind of individuals. So they can be assessed using disease or condition specific instruments, and for that matter we mean to say assessment tools. I mean, there's questionnaires, yes and no answers, or a little bit of grading kind of questionnaires, and then so for each condition there's specific assessment tools that can be used. So if there's a patient whose presentation is dominated by that one single condition, then if available, use that single disease specific instrument to assess the prognosis of the patient, right? And we still have to keep in mind that the same patient whose prognosis was, let's say the patient was at 70 years of age when their last time when their prognosis was assessed using a disease specific instrument, right? And then now we are assessing it again, and it has been like 5 years, 6 years, or 10 years. And keep in mind, the same person, the same condition, the same degree of complaint, uh, maybe with some other new ones appearing, or same complaints maybe have which have already worsened, uh, could lead on to their poorer prognosis prediction, right? So it's just big. It could, I mean, may have happened because of some other things, but more likely is that it would have happened because they've aged, and aging takes toll on us, physically and physiologically as well, metabolically as well, right? So, and this happens extremely significantly, more prominently after the age of 80, sorry, 90, right? So, after 90, expect worsening prognosis even more significantly. And then for the people who do not have their presentation being caused by a single disease or a condition, then for them we can basically assess them, while just the way we assess anyone else, right? So if they have multiple types of presentation, then it's one condition is not dominating their presentation, then just assess them like assessing anyone else, right? So in that case, basic demographics, age, gender, and sometimes ethnicity as well, right? And sometimes locality, even race as well, ethnicity, right? So these things uh, are at times utilized to basically create a prognosis for individuals, right? And the usual health elements that you'll see in a table coming up as well, right? Age, sex, comorbids, which means coexisting other conditions, and the function of the patient, functionality, how much capable at independently functioning they are. And then this functioning basically will be divided into those categories of activities that I was talking about before, daily life activities of different types, right? And obviously, another point now here in terms of prognosis to be kept in mind, think about a patient, an elderly patient who lives in the home and sees the doctors in OPD when they need to, for frequent visits maybe, but lives in the own home, compared to a patient of the same age group, same sex, everything else, let's say other all the risk factors, everything is the same, but is a patient who has just had, let's say, for whatever reason, an infectious disease or a fall or whatever, right? Had to be admitted to the hospital and has been discharged back now. So this is the comparison. An elderly of this age group living at home, and an elderly who had to be admitted and is now discharged. Prognosis for both of them, which means what is the life expectancy for so many years, right, is not the same. The one who had to be admitted in the hospital and is now discharged because they're better is much less as compared to the other one who was not even ever required to be admitted. So this is important point to be kept in mind. You may see a patient who is coming from home, but they may have been discharged previously from a hospital. So that point that they had to be admitted is an important one for your assessment too, right? So look at this now, prognostic factors risk points basically that you have here, right? Um, for 4 year mortality rates, 4 year mortality. So we are basically doing this to calculate the 4 year mortality rate of the individuals, right? So here you have the points given for every single thing here. Age, if age is 60 to 64, 1 point. This is a risk point. If the age is 75 to 79, give the patient 4 points. Right? That's the age used to give the risk points. Ultimately, it will help us assess the patient 4 year mortality rate. So what does that mean? It means how likely is it going to be for this patient, whichever patient we have now, uh, to be dying in the next 4 years, right? And risk point for age, males are definitely at more risk than the females as they age, right? That's a fact. Women live longer. You may have heard that quite a lot, right? And then they keep on saying because they give all the problems to the men, right? So it's a actual statistical fact that being a male as compared to a female is a risk factor to die early. Simple as it is, right? Because males have too many problems. So male sex, extra two risk points. Other conditions, comorbid ones, more common ones. Diabetes mellitus, 1 point. Cancer, 2. Lung disease, 2. Heart failure, 2. Body mass index less than 25, 1, which means I think it's underweight, isn't it? Uh, Current smoker, 2 extra risk points. Bathing difficulty. This aged person that we're talking about has difficulty during bathing, right? So 2 risk points if they report it, but they'll only report it if you ask about it. Less than 25. That's why they're saying. All right, less than 25 means a patient basically, um, if they get ill, they likely will not have the strength to cope with that illness, and by the end of the illness, if they recover out of it, will be even further worse than before, isn't it? So they could be underweight, malnourished, right? So, or if they're not yet exactly that, even if the BMI kind of indicates it, they would be by the time their condition passes by. So that they have much risk of other things, which basically is what we're translating into 4 years mortality chances. All right, difficulty handling finances, two risk factors. Now, what does that entail? It entails a lot of things. I would say mostly it entails related with memory, short term and long term memory problems, right? Or it may also relate with attention. You'll see, we'll talk about dementia and delirium as well. So a lot of the times they coexist. So when they are present or one of them is present, can lead on to for elderlies, not being able to remember if they've actually paid the bills, or they may pay it twice, or they may not even remember how much funds do they have in their banks, and then they may end up spending more than they have. And foreign banks actually have this thing, something like a credit card in your bank account. Let's say somebody has had an bank account that let them have overdraft if they have activated it. So it means, let's say they have a $500 overdraft. So if they spend everything that they had in their bank account, with let's say they had $1,000, they have completely finished, consumed $1,000. If they have activated overdraft facility, they can still spend 500. So it's kind of an extra credit, right? So these elderlies usually have overdrafts activated because most of the times they don't earn much, they're on pensions or their retirement funds. So they have overdrafts activated as well, and they don't even know and remember, and they end up spending more than that they have in their bank. So or otherwise paying twice for the same thing, for the bills, and ordering more than once, unexpected deliveries, right? That they don't even remember that they ordered stuff. That kind of all scenario and much more entails into difficulty in handling finances. right? So if any of such events can be reported by the caretakers or the relatives or the patient themselves, two risk factors, right? Difficulty walking several. What does it represent? They have a problem, with their memory, likely, or attention, and that means they could possibly have a neurodegenerative disease as well, isn't it? Affecting their brain too, and maybe not yet is very much significant, but if it is there, it could be developing, and it's a progressive problem likely, and then later on within next 4 years it could affect, isn't it? So two risk factors contributed. Difficulty in walking several blocks, right? Also because of multiple reasons, because of gait issues, because of skeletal muscle problems, could be a sensory issue, could be a neurological problem, could be many number of things, could be a joint issue, right? Could be basically a foot related problem. A multiple number of things could be there. So if um, it could be simply a heart attack, sorry, not heart attack, heart failure patient, right? That finds it difficult to walk a couple of blocks length, which is not much, but I mean, could be that. Could be a visual field if exactly, right? So now you're getting onto that, direction of things to think about in these patients. So it could be a million things. Um, but the risk factor added, right? So now sum of all those risk factors for whichever patient that you had, and then let's say if the points are 1 to 2, it's 2% chances that this patient will die in 4 years. And if the points are 3 to 6, 7% chances, 7 to 10, 19% chances that the patient would die. Anything more than 10 risk factors means 53% chances are that this patient would die within the 4 years. Next one. And this is kind of helping you get to that point of assessing to, you know, how much be invasive and treatment and whatnot of the patient, isn't it? Makes sense, right? Right. And the next one is a 1 year mortality rate for older patients who are discharged from the hospital. This was the previous one was for the patients living at home, right? Remember, I've established the difference between patient at home and the discharged patient. So this one, next one is because there's already bad prognosis we know compared to the living at home people. So instead of 4 year, we have this tool here available for 1 year mortality rate assessment for discharged patients. And remember that patients when of such age group, ideally when they're discharged, they are assessed um, for their functionality um, before they're discharged as well. Ideally, they should be assessed. So these things, male sex, then again, one risk point, and comorbid condition, cancer, metastatic, 8 point, cancer, not metastatic, 3 point, serum creatinine that much, albumin that much, right? And dependent in now this ADL. This stands for um, daily life activities, basically of different types. Right now, ADL in this abbreviation, A stands for activities, DL for daily life, right? And they in total have been established to be five. They're included in the next slides. A couple of slides later, you'll see them as well. So these five activities of daily life include bathing, dressing, transferring, which means transferring from bed to sofa or chair. For an elderly to be able to get up from their bed and easily sit on a sofa. This is the transfer that we're talking about. And in a life of an elderly, it's a major task, along with these other five things, right? So, bathing, dressing, transferring, using toilet, right? And eating. These are activities for daily living. Now, based on them, if 1 to 4, could be 1, could be 2, could be 3, could be 4, out of these 5 that I've just listed, if cannot be carried out independently by the patient, right? So the patient is dependent on others for bathing, or patient is dependent on other for dressing, patient is dependent on others for using toilet. So out of these 5, if for even one of them the patient is dependent, the risk factor is 2. Up to 4. So up to 4 of the activities if the patient is dependent for, right, the score is still 4, as the score is still 2. But if all 5 cannot be carried out independently by the patient, which means he or she is dependent for all 5 of them, then the score is 5. And then you sum up the points and then the score, right? So let's say if this is the patient, for all 5 of them the patient needs to depend on someone. So this 5, so and one other thing is present. Let's say, see, let's say the least male n is a male, so there you go, 6. Or let's say any of with the 2 score, let's say albumin is less than 3, right? So now the score is 5, 6 and 8, so greater than 6. 64% chances are that such a patient who has to be taking help from other people for all these 5 activities is a male, and his albumin is a little bit higher, that they may die within a year. 64% chances, right? So it's a quite insight into what kind of a elderly we are dealing with. And then you are thinking about surgeries, possibly, corrective surgeries, explorative, tests and whatnot, and the consequences. Having a surgery for an elderly of this age on its own, does not leave on a good prognosis. So because it makes them immobile for a certain period, and then immobility on its own is a topic area as well here, right? So having a surgery immobilizes the patient. So the longer this age group patient is immobile, the risk increases. Yeah, remember DVT, thrombosis, that's one of the risks. There's many more as well that we'll talk about. So important stuff, right? What's the time? The time is already over. What I will do is therefore leave you guys with these 2 graphs. And they are basically the life expectancy of men and women, right? These 2 graphs. This is for women, it says over there, and this is for men. And this green line represents the top 25th percentile, which means 25 out of 100, right? uh, at age 80 live for something like 11, 12 years, 12, 13 years. That's what it means. uh, 25% of 70 years age individuals live for like 20 years, but that's just 25%. What about the rest of the 50% remain in 75? The comments are here, right? uh, uh, these 50% of 70 years live for 15 years, whereas 25% of 70 years live for 20 years, right? Similarly, 25%, remaining 25% out of 100 now, the lowest 25, right, at 70 live 10 years or less than that, a bit less than that, right? So that's how you look at this graph. That's the age that lower percentile, 25, 50 percentile, or the upper 25 percentile that you want to talk about. And the number of years that they are expected to live on average are here. Same is the case for female, and you can compare them as well. For example, we saw that 25% of uh, 70 years females now can live more than 20. There's like 23 years maybe, and compare that with the males, 70 years, 25 and 20. So there's like 3 4 years difference between males and females, right? So you can use these graphs as well for the estimation as well. Now for the rest of the stuff, next class, right? The books to be used. Um, you can use any book, but more specifically, I've already shared, those Davidson and Harrison's with you. I'll share them again with you, but not all the chapters and all the topic areas will be present in them. Current medical diagnosis and treatment is a better book, I would say, to rely on for at least this chapter to begin with, and that's the one that I'll be sharing with you as well. All right. Hope everything that we talked about today, yeah, seems a little bit, different. Uh, but these age group individuals and their needs and their assessments and their treatments require a different approach. All right. So read through geriatrics initial assessment of old age individuals from whichever book you want to. I've mentioned the one specific book. And as I said, I'll be creating these links online and sharing them with you with the CRs. There will be a document with the links for Google Drive as well as for Wayun, and where the stuff will be uploaded. Thank you very much. Hopefully you understood what I taught today, and I'll be seeing you in the next class. Take care. Bye bye.